السلام عليكم طلاب المرحلة الخامسة كلية طب جامعة ميسان. This is part 2 for our lecture about blood transfusion. We continue our lecture. Now we'll talk about appropriate use of fresh frozen plasma. Fresh frozen plasma usually used whenever you have delusional coagulopathy. Patient receive massive blood transfusion, more than 12 units within 24 hours. Liver disease with bleeding, chronic liver diseases with a bleeding tendency. Factor deficiency, warfarin reversal, patient taking warfarin and warfarin overdose. Disseminated intravascular coagulation, whatever the cause. Replacement of plasma pheresis. Whenever you have a patient with thrombotic thrombocytopenic purpura and you want to treat by plasmapheresis, the best replacing volume is plasma. Indication for cryoprecipitate, replacement of fibrinogen, fibrin glue, replacement of vulnerable factor, and replacement of factor 13 deficiency, as I mentioned in the first lecture, replacement of qualitative abnormal fibrinogen. So it's considered as fibrinogen glue. Granulocyte transfusion, white BC, neutrophil transfusion, effective treatment of neutropenic patients, especially those patients taking chemotherapy and having drop in their white BC, obtained by apheresis of healthy donor who have been treated by GCSF. So this is half strip by from normal patient after giving granulocyte colony stimulating factors, produce measurable sustained increment in neutrophil even into the normal age, and usually should be collected and stored at room temperature and irradiated to prevent transfusion associated graft-versus-host disease, and also with cross-matching to ensure compatibility. So granulocyte transfusion need ABO compatibility. Transfusion of albumin, of two types of albumins, 4.5 and 20%. 4.5 albumin indicated treatment of hypoalbuminemia, replacement fluid plasma exchange. 20% albumin is essential for treatment of nephrotic syndrome resistant to the diuretics. Blood group, Karl Landsteiner. This is the first to describe blood group, and we talk about type of blood groups. What about blood transfusion reactions? The most important issue. We have immunological and non-immunological blood transfusion reaction, and we will talk about acute hemolytic transfusion reaction. And this is what means. It means a clerical error, wrong specimen, wrong patient. This is why we talk about the importance of checking the number or serial number of blood component with the paper asking for blood. So it is occur 1 in 6,000 to 25,000 transfusion. The patient develop back pain, fever, red urine, oliguria shock, DIC, and death within 1 to 4 hours. This is why blood should be given at hospital. And the management, terminate transfusion, and 5 patients and the unit transfused should be checked against appropriate documentation. You should take the blood that has been given to the patient, and you should make another blood group and cross-check to document the false laboratory result. What about acute hemolytic transfusion reaction? Continue the treatment of acute hemolytic transfusion reaction. Treated by we stop blood transfusion, induce diuresis by IV fluid and mannitol or furosemide Lasix. A nephrology team should be involved early if urine output is less than 1 ml per kg per hour. Report reaction to the blood bank. Send the blood bag and tube to the culture. Monitor coagulation screen. Appropriate treatment, appropriate blood component therapy will be required. There is DIC. Send serum sample for Coombs test. Coombs test looking for a direct agglutination test due to hemolytic anemia. And LDH. This will happen as hemolytic anemia. What about delay hemolytic transfusion reaction? The majority of cases, an individual has been previously sensitized to 1 or more RBC by previous transfusion. The antibody is often skid or RH system is undetectable to pre-transfusion test, but increase rapidly in titer following the transfusion. So delay hemolytic transfusion reaction is related to the antigen on the RBC surface we search for Rh positive or negative, but we don't search for KIT positive or negative. So patient with a frequent blood transfusion can develop antibody to KIT antigen, which is usually not done on a routine assessment of blood group. Clinical feature of this type of reaction is a triad, ثلاثية, fever, hyperbilirubinemia, it means hemolytic anemia and anemia. Jaundice, hemolytic anemia with jaundice and fever. Usually occur delay hemolytic classification 2 to 10 days after transfusion, and treatment, no treatment required. Further transfusion containing the implicated red cell need to be avoided. So next antigen kit should be negative for transfused patient. It is therefore important to make the diagnosis, inform the patient of the name of the offending antigen, and maintain appropriate hospital and blood bank record. What about non-febrile hemolytic, non-hemolytic febrile transfusion reaction? About 4 per 100 transfusion, Coombs negative. Febrile non-hemolytic transfusion reaction are common. What are the commonest cause of blood transfusion reaction? Is febrile non-hemolytic transfusion reaction. It's caused by cytokines such as interleukin 168 and TNF, tumor necrosis factor, which are accumulated during storage of blood component. And these are mainly found in plasma and white BC. Management: stop the transfusion, administer antibiotics, let us say paracetamol, and give miverdine in patient with severe chill, miverdine to control the rigor. And prevention is generally consensus that febrile non-hemolytic transfusion reaction can be avoided or minimized by using reduced RBC. It means we use packed RBC rather than whole blood to reduce the number of transfused white BC. Some guidelines said the patient have febrile transfusion reaction, we can give paracetamol and antihistamine alarmine as pre-medication. This is not approved. This is not in the guidelines. Prevention is generally consensus, can be avoided by leukodepleted RBC, as mentioned before. Indication for leukodepleted RBC: after second non-hemolytic febrile transfusion reaction, newly diagnosed leukemia. To avoid this reaction, to avoid reaction of white BC in the leukemic patient, and this is considered worse reaction, especially those need autologous or allogeneic bone marrow transplantation. Long-term multiple transfused patient, any patient having bone marrow transplantation, renal transplantation, they need white BC, reduced RBC blood, or even irradiated RBC. Long-term multiple transfusion, those patients sickle cell, aplastic anemia, and even thalassemia. Transfusion related acute lung injury, or what we call TRALI, transfusion related acute lung injury, and this reaction occurs 1 to 10,000, 6 hours post transfusion. Donor plasma or white BC of plasma, white BC that transfused to the recipient cause agglutination of the recipient RBC in the pulmonary capillary beds, and the patient usually came to us with feature mimic acute respiratory distress syndrome, and those patients might need ventilatory support. The treatment is mainly supportive. How you prevent it, really? Prevention by avoiding donor implication from future platelet apheresis, plasma apheresis, and possibly whole blood transfusion. Those patients blood donated, which cause TRALI, should be avoided in the future. And donation from multiparous women are most likely to contain anti-leukocyte antibody. They notice that the most common problem comes from blood donor from multiparous women. So as guidelines, European and American guidelines, they avoid blood donation from multiparous women because of high risk of TRALI complication. Anaphylactic reaction, which is IgA deficit, occur in about 1 to 300,000. Severe reaction after a few millimeters of blood component occur when exposed normal blood product which contain IgA. So IgA deficient recipient with IgA positive donor, shock, hypotension, anaphylactic reaction. And such reaction associated with the presence of anti-IgA and anti-IgA deficit recipient, anti-IgA antibody in the blood of IgA deficit recipient, which activate complement system, and there might be bronchospasm, asthmatic-like chest findings, vomiting, diarrhea, vascular collapse. If anti-IgA is detected, plasma from IgA deficit, so those patients with IgA deficit antibody need blood from IgA deficit donor to avoid this anaphylactic reaction. Treatment of anaphylactic reaction, cessation of blood transfusion, epinephrine, very, very important, epinephrine, noradrenaline, resuscitation by fluid, normal saline, because the patient hypotension, airway, patent airway, O2, vasopressor, and prevention, as I mentioned before. Post-transfusion purpura, it is occur as thrombocytopenia 7 to 10 days after blood transfusion, usually predominantly in women sensitized by pregnancy. The story is usually pregnant women with anemia and receive blood transfusion. After 10 days, they develop bleeding subcutaneously, which is purpuric bleeding due to thrombocytopenia. The most frequent cause is the presence of recipient antibody, anti-HbA1a antigen present in the platelet-specific antigen, and this antibody from the donor. And the management is HbA1 negative. Patient with diagnosed post-transfusion purpura should receive only blood product wash to remove contaminated HbA1 positive, the same as IgA deficit donor. Treatment might need high-dose IVIG and even plasmapheresis. This is very fatal complication, transfusion-associated graft versus host disease. This is the only complication which can end with death, even whatever you can do for the patient. Does not occur after most transfusion because the donor lymphocytes are destroyed by recipient immune system. However, this protective response does not occur. This commonly occurs in patients with immune deficit, and when there is specific type of partial HLA matching between the donor and recipient. Presentation usually occur up to 4 to 30 days. 4 days to 30 days after blood transfusion, and the symptoms are usually non-specific: fever, rash, anorexia, vomiting, abdominal pain, cough, and even diarrhea. The main laboratory findings are pancytopenia due to hypocellular marrow, abnormal liver function, abnormal electrolyte induced by diarrhea. The diagnosis of transfusion-associated host disease that is confirmed by biopsy of the affected skin, classically reveal vascularization of the basal layer and histocyte infiltrate. The definitive diagnosis established if the circulating lymphocytes are shown to have different HLA phenotype from the host tissue, i.e. from the donor. Management is almost universally fatal. There is no specific treatment. Prevention can be prevented by inactivating transfused lymphocyte by exposing all lymphocyte containing component to gamma radiation. So any patient with immunocompromised status, preferably to give him a gamma irradiated product to destroy the recipient lymphocyte. So this procedure should be followed for all patients immunocompromised and those patients who receive hematological cell transfusion, bone marrow transfusion. Indication of irradiated RBC, fetus and neonate have no immunity, patient with congenital immune deficiency, allogenous and autologous bone marrow transplantation, recipient of solid organ transplantation, patient hematological malignancies, patient with non-hematological malignancies and undergo intensive chemotherapy. What about allergic reaction? Allergic reaction, transfusion reaction. Recipient has antibody to the donor plasma recipient, more with the fresh frozen plasma, أكثر شيء نشوفه بالبلازما, urticaria, itching and flushing, wheezes, Symptomatic treatment by temporarily stopping the transfusion and give antihistamine like alarmine ampule. 2 ampules usually given, IV. Pre-medication with antihistamine if there is history of allergy, it's very important. Soluble allergen substance, the plasma of the donated blood react with the pre-existent Ig antibody in the recipient. This is simple complication, and the treatment is very easy. Transfusion transmitted infection. These are all list of infection can be transmitted by blood. So searching for this infection is essential before blood transfusion. Circulatory overload. Infant and elderly at increased risk of volume overload. Giving blood component too rapidly. This is wrong. Develop acute shortness of breath, heart failure, edema, 1 in 10,000 recipient of blood. Systolic blood pressure usually increase more than 50 millimeter mercury. Stop the transfusion. Sit the patient in upright position and provide O2 and diuretics. Can be prevented. So this is preventable complication, circulatory overload. Whenever you give blood for infant baby or for patient with volume overload, like patient with heart failure, renal failure, so it is preferable to give diuretics before, diuretics after the blood, and the blood transfusion should be at maximum time of transfusion, which is 4 hours. It's a very important issue. What about sepsis from bacterial contamination? Yes, platelet can cause skin contamination. Most common cause platelophoresis, pooled platelet. RBC sepsis from RBC due to Yersinia, enteric gram-positive also can occur. So the treatment is antibiotics immediately. Usually in clinical practice, very rarely we saw this complication. Electrolyte toxicity, yes, important. Hyperkalemia. Most liable patient for hyperkalemia, neonate, patient chronic kidney disease, and increased risk. Use washed blood product. Why hyperkalemia? Hyperkalemia because the blood contain different aged RBC, and RBC, whenever it is lysed, the potassium will be increased, part of life cycle of RBC. What about hypocalcemia? Yes, result from exchange transfusion and whole blood transfusion because the anticoagulant material in the blood bags chelate the calcium present in the blood, so the transfused blood usually low in calcium. So the guideline said you should replace the patient with calcium infusion after the 5 units of blood transfusion. Other complication of transfusion: iron overload. Patient need chronic blood transfusion like thalassemia, sickle cell anemia. Hypothermia, they said the blood component should be compatible with the temperature of the patient. حقيقة هو ماكو شيء اسمه ندفي الدم بغلاية. There is hot stream warmer، يعني بالضبط شلون فيرما شعر يدفي الدم يخليه نفس درجة حرارة الجسم to avoid hypothermia. Cardiac arrhythmia, yes, can occur. Electrolyte disturbance. Hypotensive reaction in patient taking AC inhibitor. Immunomodulation, immunodilution. Delusional coagulopathy after massive transfusion. عرفنا الماssive transfusion more than 12 units within 24 hours. نفكر بنعطي أكثر من 12 مطل خلال 24 ساعة. نعطي المريض plasma because they have a tendency for bleeding. Thrombophlebitis at site of insertion of central line or peripheral line, and air embolism. Air embolism, it means the giving sets contain a lot of air that can pass the venous system and cause air embolism. حقيقة بالvenous side up to 300 cc of air can cause air embolism, while in the arterial side, if the blood giving through arterial side, like those patients with central lines, up to 3 cc of air can cause air embolism, which is fatal complications. The transfusion alternative. بعض الأحيان المريض اللي يسوي عملية ما يقبل ياخذ دم، عنده beliefs religious beliefs، يقول اعطوني اخذوا مني دم، أنا أتبرع نفسي دم، وإذا احتاجيت دم بالعملية رجعوا لي البطل مالتي. هذا يسموه autologous donation. blood salvage direct donation. يعني ما يستخدم عادة هذا بالكلينيكال براكتس، بس مثل ما قلنا هاي البيشنت beliefs. عندنا GCSF granulocyte constituent factor and granulocyte monophage constituent factor. هاي ممكن نزيد لنا الوايت بي سي. erythropoietin, which is hormone secreted by the this is synthetic form of erythropoietin. Juxtagranulocyte of kidney can increase RBC synthesis, and thrombopoietin and interleukin 11. All these are substitute for blood and its component. What about therapeutic apheresis? I think this is the last slide, too long lecture. Plasma exchange and cytopheresis. Plasma exchange, we have standard indication, we have sufficient evidence. Standards proved by guidelines, sufficient evidence, let us say level of evidence 1, level of evidence 2A. Hyperviscosity syndrome, cryoglobulinemia, thrombocytic Guillain-Barré syndrome, myasthenia gravis, Guillain-Barré syndrome, peripheral neuropathy associated with monoclonal gammopathy of unsignified source. All these are standard indication for plasma exchange. Sufficient evidence, cold agglutinated disease, rapidly progressive glomerulonephritis, chronic inflammatory demyelinated bone neuropathy, pemphigus, familial hypercholesterolemia. What about cytopheresis? Whenever you have white BC count high and cause hyperviscosity syndrome, cytopheresis, leukemia, hyperviscosity, extreme thrombocytosis, platelet count more than 1 million, red cell exchange in sickle cell anemia to decrease sickle crisis, and cutaneous T-cell lymphoma. Thank you very much.